Welcome, everybody, to the Animal Heartbeat. My name is Kieran and Jose, and I'm here with my brother, my soulmate, if I may say, in veterinary podcasting, Jose Nevo Matos.
Hi, Kieran. How are you doing today?
I'm good. We just finished the second season like 5 minutes ago, and it feels like we couldn't continue without having a special. And this year we've
Absolutely.
decided to do a Halloween special, which I'm totally here for. We're big on Halloween in my family. How about you?
No, yeah, well, there's no Halloween tradition in Portugal really, but in the past 5 or 6 years, we became totally Halloween fans. So the kids are very excited. The house is full of skeletons and ghosts and stuff. So yeah, very, very excited. And very excited for this episode as well. So what's the idea? What we gonna do today?
Well, I thought it would be good to share our most terrifying heart diseases. Now, I think let's just be fully candid here with the listeners. You know, we're all friends here. We've all got to know each other very well over the past couple of years. One of our biggest nightmares actually happened with this episode in that we did it already and we recorded it and it didn't record. So here we are again, about a week later, and we decided we're not going to give you a rehash of the previous one. That is the lost episode. We will never speak of it again. So that was the biggest Halloween nightmare, and now we're going to be talking about our most terrifying heart diseases that we may see. In fact, we do see.
Shall I start?
I mean, this is going to be the best podcast ever, right? Because we've done a dress rehearsal.
I'm not sure. We'll see. Well, the listeners will tell us. So if I start, I think one of the scariest stuff we see.
What's your second most terrifying heart disease?
So left atrial thrombus in cats is pretty scary to me. Whenever we scan a cat, and again, these cats can be either they can be asymptomatic and you echo them because they have a murmur and they arrhythmia, gallop. Our cats that are already in stage C. And then in the first 30 seconds that you put the probe on the chest and you see that huge LA thrombus, cannonball-like thrombus, flipping around the left atrium, the left auricle, that's pretty scary, isn't it?
It is terrifying, isn't it?
So, we don't have we don't have really data on that, or no, we don't have guidelines on how to approach these cases, and there's always the concern that at any second that thing will go into the left ventricle and cause a massive ATE, or who knows, or block the left ventricular outflow tract and cause sudden cardiac death. So they are very, very, very scary, those guys, and to know what to do, what is right, what is wrong. But I don't know
what do you do? Because I always worry with those that if we're going to try to treat them, then we're putting them at risk of actually shrinking that thrombus and making it happen. It's almost like to me, it worries me that it's a self-fulfilling prophecy.
No, exactly. I totally agree. And I think we always talk about that, the theoretical risk or the risk of, as you said, shrinking it or maybe breaking it in pieces and then cause severe ATs and so on. But I think I have slightly changed my approach to these cases when I think I remember when I first saw these cats, maybe, I don't know, 15 years ago when I was doing my residency. And I was very worried about these cats, and I remember there were cases that we did not even treat because we thought this is not reasonable. This cat will develop a massive ATE, and this is most likely associated with a very, very poor outcome. But over time, I have changed my approach a bit or completely, because the fact is the handful, not that I can say I've seen many, but the handful of cases I have seen, they have not developed a massive ATE. There is one cat that I remember that had an ATE, but the other ones haven't. And before I ask your experience on that, if we just look at the literature, and there's not a lot of data out there, but if we just look at what has been published, the paper I always remember that I've looked a bit into these guys. Well, it was the paper on the Journal of Feline Medicine and Surgery from Joshua Stern when they looked at dual therapy. in cats with risk of ATE or ATE. So they combine clopidogrel with a factor 10A inhibitor, in that case
Yeah.
rivaroxaban, to look at safety, to see if it was safe to give those two drugs and so on, as dual therapy has been shown in people to reduce the risk of thromboemboli or thrombosis in patients with coronary artery disease and so on. So it makes sense. And so in that cohort, they had a group of 17 cats with left atrial thrombus. And interestingly, during that study, none of the cats developed an AT. Those
That's
17
amazing, isn't
cats
it?
with the thrombus. Yeah, exactly. That's very interesting.
I wonder if we find it, does that mean it's just really well attached and it's actually not going to go compared to the ones that we see that are loose and moving? It's just so hard to know.
No, exactly. That's a good point, and then we should differentiate those. We should probably, and in fact,
Mm.
on Joshua Stern paper, they don't describe that. We are not sure, but indeed, it might be different. The ones that are very attached to the left auricle, left atrial appendage, versus the ones that are jumping around and being pushed back and forth inside of the left atrium. That might be different. But even those, the fact is, I at the moment, I of course talk to the clients very carefully, explain them the risk of sudden death, the risk of a massive ATE, but we treat them, and we use this approach of treating of, in this case, we do dual therapy. We use
Mm.
clopidogrel and the DOAC, generally rivaroxaban, because hopefully the effect is stronger and is easier to do and so on. So my approach has changed a bit. I treat this case because I think it's quite unpredictable to know what will happen. Yeah, and again, our experience, we lose some cases. I need to be careful, of course, we lose some of these cases to follow up and so on. So we don't really know in some cases what happened. But I can't remember a cat that had developed a massive AT after we have diagnosed it with a thrombus. Certainly happens. But to me, the take-home messages have changed my approach, and I do treat these cases,
Mm.
even though they are very scary, and of course the risk is huge. What's your approach?
Oh yeah, well, I think I've been on a very similar journey, actually. I've definitely changed what I do. I remember really believing, and I think it comes to belief, doesn't it, when we don't have the data.
Mhm.
I remember really believing if we have a loose thrombus, well, if I give a drug which tips the balance between the pro-thrombotic and the anti-thrombotic sides of that whole cascade, and obviously in these cats with a large left atrium, altered endothelial function, and poor left atrial function, we've got an increase in the pro-thrombotic sides. They're forming thrombus in the atrium of the auricle. So I always used to think, well, we've got a loose thrombus in there. If we give clopidogrel, or if you're a person who uses dual therapy, if you use an anti-10A agent as well, then you're tipping them towards antithrombotic and you're slowly shrinking that thrombus. And if it gets smaller, it might leave the atrium, because often when I've seen them, they're too large to fit through the mitral orifice, or they
Yeah.
sort of pop in and out. So I have thought in the past, well, this is a death sentence. By treating the cat,
Mhm.
we're accelerating its demise, and by not treating, actually, maybe that's the thing to do. Maybe we just buy them a little more time on balance. However, that does ignore the fact that that's not the only thrombus that's forming. There are lots of small ones that are occurring, these micro thromboses that are occurring within that atrium, which I'm sure will be showering off to the body.
Yeah.
And if we don't treat them, we're ignoring that, and we're not doing the best we can for that side of things. But I remember being on a list serve for ISFM some years ago and reading a post there. It was for all feline medicine, and I didn't really respond to anything that was more challenging than cardiology. But cardiology, I used to, wade in on and share my opinion. And I remember there was a case where somebody said, "Oh, I have this loose ball thrombus in the left atrium of this cat." And I said, "Oh, look, I really wouldn't treat that. It's a death sentence, etc." And then Richard Malik, I don't know if any of the listeners know him. I'm sure many do. He's an incredibly experienced feline medic based in Australia. Fantastic guy. And he said in response to my post on the listserv, "Oh, you know what, Kieran? I'm just not so sure. I think that I've treated some of these cats and they do okay, and it's not a death sentence. And actually, sometimes we go back and find the thrombus has gone, and we don't know where it's gone, but it's gone. And the risk is obviously a lot lower of a massive ATE." And I remember thinking, well, what does Richard Malik know? Hey, this guy, is professor of feline medicine. What does he know? So actually, I've just come to believe he's absolutely correct. I've
Yeah.
gone on the same journey as you. I've treated a few of them, again, similar numbers, not huge numbers over the last 15 years or so. But I do you remember one cat who had a very, not loose, but it was attached to the wall, but very wobbly left auricular thrombus and moving around quite a lot. And I had the conversation with the owner, and they said, "Oh yeah, sure, let's treat." And we treated, and the next day the cat died. Now I think that was actually completely separate to the antithrombotic drug. I think we're kidding ourselves if we think clopidogrel works overnight. We all know it takes days to work, and that's why there's a loading protocol in place. Do you use the loading protocol in cats, interestingly?
Yeah, we do. And I wanted to stress that. So if we have a cat with an ATE, if we have a cat that we are very concerned that the ATE risk is very, very high, and just to remind the listeners, these are cases with smoke, spontaneous echocardiographic contrast, a thrombus, very, very dilated left atrium, very, very poor systolic function. We will use a loading dose, so 75 mg
Right.
per cat. Indeed. What I was wondering, now going slightly off track a bit, is if we should do that as a default, really. The other day I was discussing that because we had the case, sad case, that we saw the cat through our HCM clinic, asymptomatic cat with a murmur, had a large left atrium, and just large left atrium, decreased fractional shorting, but no smoke. We start clopidogrel, standard dose, 48 hours later, ATE. And then I was questioning
Wow.
myself.
That's a
Yeah,
shocker,
crazy.
isn't it? Where they
As
come
a
in
shocker. Yeah,
asymptomatic for
yeah,
screening. Oh,
exactly. After 2 days, a huge clot. And then again, you could say, well, we could have not have changed that even with the loading dose. But I was questioning myself, if we start clopidogrel and we believe there's an indication because we are worried about the risk of ATE, blah blah blah, maybe we should just
yeah,
go with a loading dose in every single cat, because if we
yeah,
are concerned, and most of them will not show a thrombus within 2 days, I see that.
sure.
But if there's any chance for them to do that, I thought I was discussing with the team that I thought maybe we should change our protocol. And if in the hospital already give 75 mg, the owner doesn't need to give the tablet to peel the cat. Yeah, and then
Wow.
it's done. The
Okay,
loading
interesting.
dose
Well, I
is
mean,
done.
I
Yeah,
don't use a loading dose in cats, but maybe
yeah,
maybe I do now. I don't know.
yeah,
It's
yeah.
interesting, isn't it?
Just to say that again, just looking, the only data really at the time I can always remember about this stuff is a Joshua study, and then Rosie Payne's study, that very neat study that Rosie Payne published at the Journal of Veterinary
Oh
Cardiology, where
yeah,
she looked
looking
at
at
risk
outcome.
factors. Yeah, exact
Yeah.
outcome, and basically risk factors of cardiac death in cats. And she split that into sudden death, congestive heart failure, ATE, and looking at her data on ATE, so risk factors associated with risk of death due to ATE. In her univariable analysis, cats with smoke or a thrombus had an increased hazard ratio for death due to ATE. But then, in fact, in multivariable analysis, when she adjusted for other variables, the final variables in a model of risk factors for death due to ATE were the presence of arterial thromboembolism, or at presentation, or decreasing LA fractional shortening. So interestingly, smoke and thrombus was not there. So just saying that maybe it's not as straightforward. Maybe it's so. Well, I think
Yeah.
really is, I don't want to give the false impression to the listeners that will not happen. Certainly will happen, and is a huge risk factor. But I think to me the take-home message is not all cats will develop a massive AT, and these cats are worth treating. At least that's, I guess, our opinion.
I remember the sort of flip reverse of the other case where this was a loose ball thrombus, and I just thought, wow, this is a really high risk cat, a little female 5-year-old cat. I remember she was beautiful, kind of tortoiseshell, calico for the American listeners, and she had really bad cardiomyopathy. I was in a real quandary about this, and I remember saying to the owners, I don't know if we should treat. Here are my reservations. Here's what I think. We've got a bit of an evidence vacuum, and it's up to you, basically. And they were smart people. They could take on that information, and they went away and they had a talk about it at home. And they called me up the next day and said, okay, we accept the risks. We just want to do what we can do, and we want to treat. And the cat went away on clopidogrel. And then maybe, I don't know, I sort of lost it to follow up. And they called me up about, I want to say about 8 or 9 months post diagnosis. And they said, oh, hey, just to let you know about the cat and how she's doing. And I looked the records up and I thought, crikey, I I just presumed she was dead. And
Yeah.
there she was at home
Yeah.
doing
So,
great. And I said,
yeah.
oh, hey, how about you come back in for a scan? And they said, oh, she really hates the travel. But they went to the local vets and they put the scanner on and they couldn't see a loose intraatrial thrombus.
Yeah.
They said,
Yeah.
yeah, sure, the cardiomyopathy is really bad, but they couldn't see anything throwing itself around the atrium. So maybe it did go somewhere. Maybe it did shrink down and go
Yeah.
somewhere. But that cat survived whatever embolus occurred and was doing great. And the owners were super happy. So actually that was a real game changer for me, that case. I think to not treat is to neglect all the other smaller thrombi. And I don't think that it is a self-fulfilling prophecy. But I think it is terrifying when we see it.
Yeah. It is, it is. But just to echo what you said, this is again another example that we are so bad at predicting outcome in cats. And that's why I think generally our approach is we try to treat every cat, even if congestive heart
Right.
failure looks horrible or have a bad AT and so on, because you never know. There are some cats that then will have a pretty good and decent quality of life and live for longer than we would have ever expected. I think we are much better at predicting survival and outcome in dogs, maybe because we have large clinical trials. Okay, how
So
can you beat this?
well, I was going to say, I see your intraatrial thrombus. I acknowledge that's terror right there. It really is. But I wanted to talk about something which we know in a very thorough way, a very well understood way in people, but we don't know so well in dogs and cats. But I believe it's there, and it's the phenomenon of something called channelopathies. So genetic mutations in ion channels, which cause problematic action potentials. So it can lead to after depolarizations, it can lead to prolonged repolarization or shortened repolarization. And all of these things can predispose to arrhythmias. So these are effectively inherited arrhythmias. There's nothing more terrifying to me than a baby, a puppy, who has got something that could put its life at risk. And I think these things are out there, and we see them in dogs often as incidental findings. And often they don't have a high troponin. They don't have anything that stands out. They may have a normal echo, depending on how bad the arrhythmia is, but their arrhythmias are terrifying. And I think in humans that there are multiple different syndromes described. There's the Brugada syndrome, and this brings back a slightly terrifying memory for me, actually, when I was honored to be speaking at a VEPA meeting, the Spanish Veterinary Specialists Congress meeting. And it was all online because this was back in lockdowns and COVID and things. And I was speaking on the bill, and I realized the day before that the person I was speaking after was one of the Brugada brothers who had described the Brugada syndrome. So this was Josep Brugada, who I want to say had done all the sort of cardiac electrophysiology, and I think one of his brothers described the genetic mutations, and this guy did the most fascinating lecture. I joined it alongside my father-in-law, who is a retired pulmonologist, a doctor, but being a pulmonologist, he'd done quite a lot of cardiology in his work. So he said, oh yeah, Josep Brugada, oh, he really knows what he's talking about. And I was thinking, oh, great, fantastic.
No
So
pressure.
Brugada did this amazing lecture.
Yeah.
And I then followed him and was like, hello, little old me talking about atrial fibrillation.
Yeah.
That's a terrifying
Yeah.
Halloween memory for Brugada. But the disease itself is much more terrifying.
Yeah.
And these are mutations often in sodium channels, and they can lead to effectively ventricular tachycardia, ventricular flutter, and polymorphic ventricular tachycardia, which of course poses a risk of ventricular fibrillation. And there are various ECG criteria to diagnose the Brugada syndrome. There are also short QT syndromes and long QT syndromes, which can be caused by mutations in potassium channels. And these things can predispose to, again, the same thing. They can predispose to atrial arrhythmias in some cases, but mostly it's the ventricular arrhythmias that are the biggest concern. In dogs, I think we do see these diseases, and very kindly, Kate Mears has sequenced a couple of puppies that I've seen with normal echoes, normal troponins, no clinical signs, but horrible non-sustained polymorphic ventricular tachycardias. And they seem to be worse. The ones that I've seen, one Italian Spinoni, one Labrador, one Boxer dog, I think another breed as well. And they often have been worse at lower heart rates. Now, the dogs that are out there in the literature, the most commonly described one is the German Shepherd inherited ventricular arrhythmia. Now, that may be something different. It is certainly inherited, but it may not be a true channelopathy in that they seem to grow out of it. If they survive, they make it to 2 years, 2.5 years old, often the arrhythmias disappear. Um, it's also described that these different ion channel mutations are described in the Rhodesian Ridgeback, the inherited ventricular arrhythmia, which there is a commercial test for, and also the Cocker Spaniel. There was a sodium channel mutation described in the Cocker Spaniel associated with these runs of potentially lethal non-sustained polymorphic VT. So we see them out there. We know that they exist, but they're not very well characterized. And I suspect we massively underdiagnose them as vets because these dogs are asymptomatic. The last couple of inherited ventricular arrhythmias in German Shepherds that I've seen have been cases that have been anesthetized for neutering, and they've developed horrible VT or salvos of ventricular tachycardia under anesthesia or under sedation. And then either the procedure's been reversed or they've sort of rushed and completed the procedure, recovered the patient, and then referred them for cardiac assessment. And although I think in the German Shepherds we can treat them maybe with sotalol mexilotine, as I know have been described, I'm not sure I've had much success in treating seemingly these other cases, the Boxer dog, the Labrador, the Spinoni. They've all dropped dead despite our best efforts. And we really tried to reduce the arrhythmia frequency. In the Spinoni case, I remember this dog, we were really intense with antiarrhythmics. And I felt like things were getting better, but then the dog dropped dead. So I think these are terrifying arrhythmias that could be present in the background that we just don't know about necessarily, and they may be having much more of an impact on dog populations than we can really quantify. What do you think about that? Have you got any experience with these cases? You must have.
Yes, I've seen a few cases, not many certainly, but a few cases. They are very interesting, I have to say. Very scary indeed, and but very interesting. And it's great that in the past few years, as you mentioned, there have been some papers out there describing long QT syndromes in certain breeds. That's interesting. But I agree, the same experience, similar young dogs with very, very nasty ventricular arrhythmias. The ones I remember had structurally normal hearts. And troponin, as you mentioned, because then, of course, our top differential would be myocarditis, young dog, nasty ventricular arrhythmias. But then troponin generally is underwhelming or just a bit increased, but not sky high as we see with classic myocarditis cases. Totally, so similar experience. And then what is scary, as you were saying, how do we treat them? And I remember a case, just to echo again what you said, because we generally, what we learned in the vet school and probably read in most books still is the risk of sudden death is during exercise, during bouts, bursts of intense exercise, excitement. That's when we all are worried about sudden death in cardiac patients, which certainly is a risk factor in many diseases. But these cases, as you were saying, some of these channelopathies, the risk is during slow heart rates and that transition between sleep and awake state and changing sympathetic tone. It's very interesting. And the other day we had a case, maybe 2 or 3 weeks ago, which was outstanding nurse really care. Just shows how important nurses are in our jobs. Was I can't remember the breed, but a young dog with ventricular arrhythmias, nasty ventricular arrhythmias. We start the dog on sotalol. And the arrhythmias were the dog was in the hospital, seemed to have responded to our initial sotalol therapy. And then the nurse noticed that when the dog was quiet in the kennel, he had ventricular arrhythmias. And as soon as they would take the dog for a walk, the dog was on telemetry, the dog would develop sinus tachycardia and the arrhythmias would disappear. And we made him quite bradycardic with our sotalol, even though it was pretty standard dose. And so very, very interesting. And then, we combined mexilotine, as you said, and Galt sort of showed that, at least in the German Shepherds, sotalol by itself might be pro-arrhythmic. And it was very interesting. I think it was one of the very few cases I remember to have seen clearly that during slower heart rates, when the dog was quiet in the kennel, had a lot of ventricular arrhythmias. And then as soon as the dog would stand up and walk around and go outside, the arrhythmias would disappear. And the same pattern, we saw the same pattern in the Holter dam. Very, very, very interesting. Very interesting, and but in one hand frustrating, as you were saying, because our antiarrhythmic therapy, our medical therapy, might not be good enough to avoid or to significantly reduce the risk of sudden death.
Oh, you see, in
Yeah,
humans, they place the
yeah,
implantable cardioverter defibrillators to treat these cases.
yeah,
That's
yeah,
a primary,
yeah,
well, not primary prevention. That's a secondary prevention because
yeah,
often they've had events which have caused them to have a diagnosis, unless there's a family history of sudden cardiac death. But I remember on a cardiology externship at a pediatric cardiology center, seeing kids come in with their ICDs, their implantable cardioverter defibrillators, and the nurse technicians there having a chat with the kids, saying, "Oh, how have you been doing this week? You okay? Oh yeah, all right, not bad. Playing a bit of football. Oh, you shouldn't play too much football. No competitive sports, etc. Let's just check your ICD." And they look at the data from it, which of course self-monitors. They check it and it says, "Oh yeah, a couple of episodes of ventricular fibrillation in the week," which is terrifying in itself because you just think of that as being the lethal
yeah,
arrhythmia. So this kid had a couple of episodes of abortive death that week, and the ICD had saved him. And she said, "Oh, did you feel it?" And he said, "Oh yeah, felt it go." And you can feel it like a punch in the chest, apparently, having these ICDs. Now I know that Roman Perriot and others have been working on ICDs in dogs for a long time and trying to get it right, trying to get the implantation right, trying to get the programming right so that they could be used therapeutically. My understanding is that currently they're not at the point of using them therapeutically. And looking at the literature, the case reports that are out there, there's no studies per se, but the case reports that are out there seem to be that the devices have real trouble in dogs distinguishing between sinus tachycardia and ventricular tachycardia because of oversensing T waves, because dogs have very big T waves. And I think that is problematic because looking at the case reports, there was one dog that was shocked into VF, then shocked out of VF because it shocked on the T wave, thinking it was synchronizing it with an R wave. And it put the dog into ventricular fibrillation. And then it brought the dog back out of ventricular fibrillation. And of course, each time the dog's being punched in the chest, and it's very stressful potentially for the dog because they can't rationalize what's happening. In the cases that are out there, that there's an association between these devices and potentially death and also infection. It seems to be a problem that these devices get infected more than pacemakers, and maybe that's just lack of familiarity of placing them. I don't know where the current research is on them. I haven't seen much in the literature recently, and I wonder if they're
yeah.
continuing with it. Is it something you've got any insights into? Have you heard anything about them?
No, well, in fact, at the last ECVM, I think Roman Pariot was there, and then someone asked him again about ICDs. I think there was a talk about sudden cardiac death potential or something like that.
Right.
And he mentioned that again, that the settings for ICDs in people, apparently you cannot change the settings. They are not, you cannot program them.
Oh,
And
really? So
and
it's
as
not
you were
something you can refine, huh?
it cannot change. And then, as you were saying, the device will recognize sinus tachycardia due to the faster heart rates in dogs as fibrillation, and dogs would get inappropriate shocks. The stuff I have read about ICDs is more related to HCM, and it's still a
Yeah, of
really
course. Yeah.
tough really a tough decision because absolutely they are the only way to prevent sudden cardiac death. But people also then the decision on when to implant the ICD is tricky because of course they only want to implant when there's certain a risk of sudden cardiac death. There are many people that get ICDs and never then have a shock, an appropriate
Oh,
shock.
really?
And and apparently people live in that they're in huge anxiety because the shock, of course, hurts, and that they
Mm.
never know when they might be shocked. So it's also I think in terms of quality of life and so on, it's also tricky because people will get shocks, inappropriate shocks, and so I think it's a very, very tricky decision to know exactly when to do it, when is the right time to do
Yeah.
it. And if you look at that, at least HCM data and so on, that some people will never get a shock. It's crazy. You get an ICD and then you will never have fibrillation again, that kind of stuff, or you get
Amazing.
inappropriate shocks. So it's a tough decision apparently. But as you were saying,
For me, if someone said, "Hey, look, you're at high risk of sudden cardiac death because of your arrhythmias. Do you want to take a punt on the ICD?" I'd be saying, "Give me the device."
yeah,
Like
yeah, yeah,
let me take that
yeah,
chance. But that's just me,
yeah.
and it's not for everybody, is
Out,
it? Not everyone wants a
yeah.
diagnosis.
Yeah, yeah, yeah. I agree. I would think the same. Now, when we talk about you talk about the Brugada brothers, which I think I love these
Mm,
kind of stories and a bit of medicine history. In a second, we'll be talking about something else related to medicine, medical cardiology history, and but also regarding the ICDs. there's an interesting, I can't remember the name of the first, I think it was a surgeon that proposed the ICD suggested to implant intracardiac defibrillators. And there is apparently a famous letter to the editor from a famous cardiologist, I think Brownwald even, I believe, that he wrote to the New
Oh,
England
wow.
Journal of Medicine saying that this was a very silly idea, that people could die
Yeah.
of the shock and they could be electrocuted to have an ICD. And apparently Brownwald described the external defibrillator, and he was very concerned about the idea of implanting intracardiac defibrillators. Just to
Mm.
say, very interesting, very, but how brave are you and to say, okay, let's implant an intracardiac defibrillator, isn't it? Let's shock uh,
I,
people. It's
honestly,
just, yeah,
I think the history of human cardiology
yeah,
is just fascinating, isn't it? Have you
yeah.
read a book called The
Mm.
Matter of the Heart?
No.
Oh, I would highly recommend it. And to all
Yeah.
the listeners out there, I would highly
Yeah.
recommend it. I again, it was stolen by my father-in-law from me, so I can't lend it to you. But it's a fascinating book, and it's taking you through the history of heart surgery in people, right from talking a little bit about the 17th century and very early kind of descriptions. Oh, we can't touch the heart. You can't.
Yeah.
It's imbibed with spirit. And
Yeah.
actually, that didn't really change till the 1930s, that people started thinking you might be able to operate on
Yeah.
that. So my two favorite stories. Let's just share these, if I may. My two favorite human cardiology stories, apart from the one that you're about to relate, actually, which I do know from our previous dress rehearsal of this episode. Um, the the first one that I really love is actually relates to Eugene Brambot, who is a guy who was a real pioneer of understanding HCM, and he worked at the Mayo Clinic, and I think, is that right, or the National Institute of Health? I don't know, somewhere famous in the US, in the '60s, and he was describing obstructive HCM initially, and of course they didn't have echo. It was all done with pressures, invasive pressures, and monitoring and things, and they defined that obstructive HCM as a thing. And he was working with a surgeon called Glenn Morrow. Morrow began his procedure, the Morrow procedure, as you know, that the septal myectomy, where they went on the beating heart and they went down the aorta and chopped a bit of the septum out to remove the obstruction. And these patients massively improved their symptoms of faintness, fatigue, chest pain, palpitations fell away, and their longevity seemed to be improved by this procedure. The really cool part of the story, or not so cool, maybe a really interesting part of the story, is that latterly, in his 50s, Glenn Morrow developed the symptoms of obstructive HCM. And Bramvalt was pretty convinced on physical exam on history that this is the problem. Morrow hid it and didn't want to tell him until he fainted one day in the car park. And Morrow refused to let Bramvalt cath him, and he refused any surgery from anybody else. So he died of his hypertrophic cardiomyopathy in the
Yeah.
end. And he,
Yeah.
he refused the treatment which he pioneered and proven to be highly successful. That's story number one. The second story is much more fun, actually, and it's about nuclear pacemakers. And it's pacemakers that battery life was an issue with implantable pacemakers, and they decided, hey guys, let's use radioactive isotopes. So these pacemakers had hundreds of years of battery life, and they were used for a little while in the US. But the main issue with them is they needed massive shielding to protect the patient from radiation poisoning. So what they did was implant these massively well-shielded pacemakers into people. And there's actually a case, maybe more than one, of where it acted as a life-saving device against a bullet, where the bullet hit the pacemaker and ricocheted off, saved the guy's life, and actually it still worked afterwards. So
That
it's quite
Indiana
amazing.
Jones kind of stuff. Yeah. Yeah. Nice.
And there are people out there in their 80s and 90s who
Yeah.
still have these nuclear pacemakers just ticking away, decaying radioactive isotopes. I'm not saying it's a way we should go right now, but it's interesting stuff, isn't it?
No, that's so interesting. Those yeah, medical histories, medical stories, and so on are so interesting. And then maybe that brings me to my second choice of the scariest heart diseases.
Yeah.
Not necessarily the scariest, but it is Halloween. I thought I would pick a cyanotic heart disease, a blue dog or blue cat, blue babies. And so the most common cyanotic heart disease we see is tetralogy of Fallot. Apparently, also the most common cyanotic heart disease in people. We do not see fancy, more advanced, complex cyanotic heart disease in dogs or cats as they see in people for obvious reasons. These patients have very limited survivals, but we do see tetralogies of Fallot. And just to remind our listeners, the tetralogy of Fallot is a conotruncal defect where there's a dexter position of the aorta. The aorta, there's a malalignment between the aorta and the intraventricular septum, and that will then cause all the different defects. The malalignment of the aorta will cause a large VSD, and then again the dexter position of the aorta will squeeze, will cause an obstruction to the right ventricular outflow tract, and then plus right ventricular hypertrophy. This makes up the four defects. And the most dogs, cats will develop a right to left shunt and erythrocytosis, which then there are different approaches for these polycythemia erythrocytosis, which some of them may also be a bit spooky, I think. So one option for patients with polycythemia secondary to tetralogy is, of course, repeated phlebotomies using hydroxyurea. Phlebotomies are a pain in the neck in these cases because they may need to be repeated very frequently. These are cases with very high hematocrit and so on. But there's another spooky approach to these cases. Can you?
Is
Do you
it
have some
is it
experience?
vampires?
Close. Can you tell us about your experience with leeches, Kieran? Because I have never used
Yeah,
them.
leeches. Hirudotherapy. Hiridin is the anticoagulant in the leech saliva, which is actually a pretty critical part of hirudotherapy because each of the medical grade leeches that you attach to draw blood will draw about 10 mils of blood. And then the hiridin has prevented the coagulation at the site of attachment, and you get an oozing of approximately another 8 or 10 mils of blood afterwards. So each leech can take about 20 mils. This means that from a small patient, you could use a few leeches to perform phlebotomy, if you like, at home. And it means that a particularly anxious patient, dog or cat, small dog or cat, doesn't have to come to the clinic. And often this can be done without any sedation at home by the owner. Now, you've got to have a particular type of owner and a particular set of circumstances around that case. So hirudotherapy is not something that we reach for very often, but it's a cool thing to do. And it's something that, can be practically useful for them.
Yeah.
I wouldn't suggest using vampires. I think leeches are probably your first line for at-home blood draws. But you never know, with it being Halloween and all, there's possibility there.
Yeah, that's indeed very cool. The other option, of course, is a surgical option, which brings us to the another very interesting medical story and very important history in cardiology. But so one approach when patients, dogs, cats, humans have severe polycythemia to manage the tetralogy of Fallot, of course, either you do corrective surgery and correct the defect, which has been described rarely in dogs and cats. I think there's a couple of case reports.
It's big
of course,
guns to do that in a dog.
Yeah,
isn't it?
it's a big thing. Exactly, need to completely correct the defect. The other option, as one of the main issues with this disease, is a decrease in pulmonary blood flow due to the severe outflow tract obstruction, right ventricular outflow tract obstruction, large VSD, is to try to increase the pulmonary flow. And this, which is a surgical procedure called Blalock-Taussig shunt, which has an interesting story to it and part of very important history in cardiac surgery. So the BT shunt was the very first cardiac surgery ever done. As Kieran was saying, at the time, it was believed that you could not touch the heart. Humans, we could not do surgery on the heart at all. And so Blalock-Taussig Blalock was a pioneer there. But what is very interesting, again, bring a bit the interesting history in cardiology, that Taussig, she was a cardiologist, a deaf cardiologist apparently, and
That's
she
right,
was a
yeah.
pediatric, pediatric cardiologist, which makes it her even more impressive. And she realized that pure clinical observation, which makes it incredibly neat. She realized that children that had tetralogy of Fallot and the PDA had much better outcomes than children without persistent patent ductus arteriosus. And so she talked to Blaylock, a famous surgeon at the time, discussing with him if he would be able to create a shunt, a systemic arterial to pulmonary shunt, similar to a PDA in those children, surgical shunt, anastomosis, to try to improve pulmonary perfusion. This was a huge milestone and the very first heart surgery ever done in children. But what is very interesting, many interesting stories around this, but one was that Blaylock worked with Vivian Thomas, was Blaylock lab assistant, and he was the one that indeed developed the surgery in lab dogs. I don't know, I think he did up to 200 dogs where he developed this shunt and the anastomosis and developed the instruments then to do the first surgery in a child, in a girl. But very sadly, of course, at the time, he was just a lab assistant. He didn't have a medical degree. He was Afro-American. And so he was not named, the procedure was not named after him. And so he didn't get the credit at the time for his huge impact on developing this surgery. And recently there was a movement, again, I believe a letter to the editor, asking the scientific community to give the deserved credit to Thomas, and asking the scientific community, the medical community, to start name this shunt BTT shunt instead of BT shunt, for Blaylock, Thomas, and Taussig shunt, which is very interesting and crazy, isn't it? Crazy that these guys have achieved, and pure legends. It's just unbelievable.
It's really amazing. And I think that whole story about Vivian Thomas's role is actually really important to acknowledge how vital his skill was to that procedure going ahead and carrying off. Because if it hadn't gone well, the hospital probably would not have let them do any more. And
exactly.
Vivian Thomas was in the operating room and was able to look over Alfred Blaylock's shoulder and say, "No, don't do that. Put that a little bit more to the right. You want to go more medial. You want to, do this," and give him the advice. But he wasn't allowed to handle the tissue because he was employed by the hospital as a janitor, and he was a scientific lab assistant. But because of segregation and the laws around race at the time, he wasn't allowed to be headlining there. But actually, he did write a memoir in the mid-'80s, and that's quite an interesting read. And that's been turned into documentaries and movies. I think it was a movie like 20 years ago about his work with Blaylock.
Something the Lord made, I think.
That's the name of the autobiography. Good. So, blue dogs, blue cats, blue babies, terrifying. I'm going to link it back to human cardiology again. And this is a rare disorder in dogs. It is something we do see in dogs, but not especially commonly. In people, it's a little bit more common. And this is, I think, one of the most terrifying diseases. But what's really interesting about this is a disease where there's been a huge leap forward in medical research based around a case that came in as a veterinary cardiology referral. And I think that actually takes quite a depressing, dark, horrifying story and turns it into something that, like Halloween being turned into a festival, right? Something slightly horrible, slightly dark, into something uplifting and light and positive. And this is a story about Duchenne muscular dystrophy. So this is a type of muscular dystrophy which is as yet incurable. And this is an X-linked condition, which means it has a huge predominance for males. When we think about the incidence of it in males versus females in humans, then in males it affects around 1 in 50,000, and in females it affects about 1 in 50 million is the estimate. So it's much more common in males and females. And this is a disorder where all of the muscle, including the cardiomyocytes, are affected, and it's a variety of different mutations in the dystrophin gene. There are some other effects of this. It can cause things like changes in fat content in the body, changes in appetite. So sometimes these people are not only weak in their muscles, but they can also be prone to obesity. It can cause spinal malformations and scoliosis, and also things like learning disorders or intellectual disabilities. And these people can really have a very progressive change. So their first signs can be around age 4 in humans, and they can progress quite rapidly, where they lose muscle tone and develop weakness standing up, to the point where often by age 12, most of the males affected are non-ambulatory and are bound in a wheelchair, needing a high level of care. In terms of the effects on the heart, they develop a very severe DCM phenotype, and eventually they can develop heart failure. So they can be managed, and cardiologists, medics try to manage them as best they can, but ultimately they experience respiratory muscle failure, and that's the end for many of these patients. So this is heritable, and there are genetic screening programs there in families with a history, but it's terrifying that this could be out there. It could occur in your family, and the first time you know about it is when your child is diagnosed, potentially. That to me is really, really scary stuff. Now, it does happen in dogs, or at least something very, very similar occurs in golden retrievers, which is known as, predictably, golden retriever muscular dystrophy. I think occasionally it can occur in other breeds of dog as well, and they're often young dogs with a DCM phenotype and very marked changes to their musculature elsewhere. So I think in the golden retriever, it's defined, as early as 6 weeks of age, they can have early signs, and actually they can develop these particular atrophy of the muscles over the head, the trunk, abnormal joint motion, and this sort of scoliosis of the spine. So at the moment, this is not a curable disorder. And I do remember a really horrible experience seeing practice when I was doing some externship work at Great Ormond Street Hospital, and being in the muscular dystrophies, the cardiomyopathies clinic with one of the consultants. And this kid came in who was sadly non-ambulatory. He was wheelchair bound. He was quite overweight, and clearly was having a very tough time. He'd had a history of heart failure. They were monitoring his DCM, and the consultant had a whole conversation with his parents. And they were very accepting of the situation they were in, but it was incredibly sad. And he described to me what I've just described to you about Duchenne's, and how this was headed for a very dark ending in the not too distant future. And it was really awful to see that. And the next appointment came in was a much younger child, maybe 5, 6. And the kid bounced in, super happy. To me, he looked absolutely normal. And he had the early stages of Duchenne's and wasn't showing such severe signs and wasn't so symptomatic. But that child was destined for the same fate as the previous one. And I just found that a really terrible situation to be faced with. And I mean, of course, it must be a million times more terrible for those children, for those parents, of course. But the uplifting part you've all been waiting for is that a few years ago now, 10, 11, 12 years ago, I can't remember, a dog presented to the Royal Veterinary College Cardiology Service, just as a standard referral. It was a young dog with a DCM phenotype. And that dog was diagnosed with potentially an inherited myopathy. I think there was also muscle wastage as well, or something else that hinted this wasn't just a myocarditis or a DCM phenotype. It was something a little bit more troubling than that. And it was owned by a breeder who didn't want to take on the treatment responsibility for the dog and was considering euthanasia for this pet, this individual. And actually, because there was something a little unusual about this case, it wasn't a standard myocarditis DCM. There was something going on here in it being a young dog with the muscle wastage and everything else. The cardiology team spoke to Richard Piercy, who is a very experienced neuromuscular researcher. He does a lot of work in horses, but is not averse to working in other species as well. And he was very interested and said, well, maybe there's an opportunity here. So what they did was they bought the dog, and they have set up a research colony of outcrossed beagles with this dog, and these dogs have transformed our understanding of this Duchenne's-like muscular dystrophy, and actually have opened up new treatment avenues for potential gene therapy in the dogs, but also, of course, tracking back to people. What do you think about that, Joe? So you've got some more insight into that, haven't you? Because you were working alongside the research group there when you were doing your PhD.
Yeah, I was not involved in the project at all, but just listened to some of the updates from Richard Pierce's group and so on. And as you were saying, I think this is an example of an absolutely outstanding research project. And I can only
Yeah.
imagine the amount of work and that was needed to be able to create this colony. These dogs are very well kept, are very, very carefully monitored. And so it's just absolutely outstanding. And the data that is coming out from that group is I believe very promising and exciting.
Mm.
But as you were saying, I think I remember exactly some talks from Richard Piercy describing the condition in children, as you said, and it's very sad. It's very, very sad to imagine young children that end up dying at very early ages and end up in ventilators and so on due to muscle weakness. Is a horrible disease, but it's fantastic that a colony of dogs might be helping these children and helping dogs also in the future. As you were saying, I think that the treatment, my understanding is, which is also very cool, is they are doing gene editing and gene therapy by trying to convert Duchenne's into Becker muscular dystrophy. That means that, as you were saying, with Duchenne's, the dystrophin, the muscle protein is completely absent. There is haploinsufficiency. The mutation, the position where the mutation happens in the protein, causes a completely absence of the protein. The protein cannot fold, and is eliminated from the skeletal muscle and cardiac muscle. And there's but if the mutation affects another locus, another place, focus on the gene, it will create a protein, a dystrophin, that is not normal, but at least is partially functional, with a much better outcome, long-term outcome than Duchenne's. Their muscles are not perfect, are not normal, but can have longer survivals. And so I believe the idea from Richard Pierce's colony, the RVC colony, is doing gene editing to convert Duchenne's into Becker's, which I think is absolutely mind blowing, to try to convert
It really is, isn't it?
isn't
That's
it?
amazing.
Into, by gene editing, just change where the mutation is happening and turning that dystrophin into a close to functional protein. That's brilliant. And it is very sad disease, but hopefully with the One Health umbrella and idea that dogs can help people and vice versa. That's fantastic. Fantastic.
And how cool that somebody in a clinic can pick up on that case that's just a little bit unusual, and because they've got a bit of a broader knowledge than just what they see every day, they can identify that case and say, okay, let's link this in. Let's have some conversations with some people and see if we can either do more for the dog or do more for the world. Let's make this a big picture thing. And I think that's really inspirational to me as a clinician. So this is a story about veterinary cardiology actually transforming the landscape potentially for a huge number of human patients with Duchenne's every year. So I think it's dark start, uplifting finish. Plans for Halloween, Jose, after our terrifying stories. I'm going to have nightmares about these diseases now. I'm going to wake up thinking I'm having polymorphic ventricular arrhythmias in low heart rates. What's the most terrifying of these disorders as far as you're concerned then?
Well, I think Duchenne's is indeed is the saddest one, and it's just horrible to imagine young children that cannot play, cannot feel weak. That's absolutely devastating. Absolutely devastating. I think that's by far the scariest one.
I think it is the scariest, but I think in terms of our patients, we don't see that muscular dystrophy very much in dogs. And I think as a veterinary cardiologist, I mean, as the male, Duchenne's is terrifying. I think as a parent, Duchenne's is terrifying. I think as a veterinary cardiologist, for my patients, it's less scary. And I think, I think for me, the thing that causes me to lose sleep and causes me to worry is your example of the intra-atrial thrombus.
Do you think does that mean that HCM is the most important heart disease we see in clinical practice then?
Oh,
I
now,
don't
I
know.
mean, let's back that truck up a little bit. I'm not sure. I'm
I
not
think that's
sure
what you
I would
said.
say that. I
No,
think I think
yeah.
there are cases there that can be more horrifying than others, for sure. For sure.
Yeah. No, yeah, yeah, I agree. I agree. It's very scary, especially, and as we discussed, it's just we don't know what's the best way to treat these cats. And ATs are absolutely horrible things to witness. And yeah, I agree. It's very, very scary.
I think for the
Well,
cats and the cat owners, that's the one that
yeah,
brings the nightmares for sure, isn't it?
yeah, yeah, absolutely, totally agree. Hey, but was still very cool, scary, but very, very cool to discuss this case with you. What are your plans for Halloween?
Well, I mean, I'm about to go and do a séance and bring back the spirits of some much loved family members in preparation for, the coming days. It's very important that we acknowledge, All Saints' Day, All Souls' Day coming up. These
Yeah,
are big
yeah,
deals. Halloween is
yeah.
but an ancient pagan festival, and pumpkins are just a hangover from the Irish carving turnips. So let's think about all
Exactly.
these aspects for me. You're gonna carve
Absolutely.
some pumpkins or some turnips, whatever you like.
Yeah, yeah, pumpkins. We just went to buy some pumpkins today. So yeah, that's the plan. Very, very
Um,
exciting.
I'm sitting here in a 200-year-old house that I don't live in, surrounded by beams in the ceiling, and over my shoulder here, the listeners can't see it, but there's an empty chair. And I'd like to say that actually during this podcast, I felt a presence sitting in the chair, and the room's been getting colder and colder. So I think I need to go and deal with that before the night is out.
Very, very good. Hey, great stuff again. Thank you very much for listening. Please do not forget to follow our podcast on the socials. Our handle is heartbeat_pod. And stay tuned. You never know when we'll record a new special episode or something like that. Um,
Absolutely,
happy
we can't stay away.
Happy Halloween, everyone. And again, thanks very much indeed for listening. And yeah, send us some feedback and let us know what are the scariest heart diseases you have ever seen. All the best.
Take care now. Bye bye.